This video is about heterochromia of iris. Now there are two terms, heterochromia iridium and heterochromia iridis. Now heterochromia iridium means both eyes having different colors, okay? Then heterochromia iridis, it means same iris having different colors in one or more regions from the rest of the iris, that is heterochromia iridis. Now, how these terms are derived and how the words, origin of these words, like iris is a Greek word and it means rainbow. Again, these all terminologies are derived from Greek language Greek. So, iris means rainbow, heteros means different, then iridis pertains to one iris, then iridium pertains to both irises. Chromia means color or pigmentation. Now there are three main types of heterochromia. Honestly, I knew only complete and sectoral. I didn't have any idea about the central heterochromia up till now. So there are three main types of the heterochromia: complete, sectoral and central. Complete heterochromia means one eye of a person having different color than the other eye. It involves the complete iris. Complete heterochromia means both eyes having the different colors, and it involves the complete iris. Like this eye is having blue color and other eye having the brown color or gray color, like that. Central heterochromia. Central heterochromia means ring around the pupil has a different pigmentation from the rest of the iris. Usually it is central, obviously central, so it is near the pupillary margin. Iris, the pupillary margin of the iris is involved. So it is a central heterochromia, and this central iris having the ring of the central iris near the pupillary margin having the different color than the rest of the iris, and normally it is seen in hazel eyes also, because in hazel eyes normally what is seen at the center, there are usually brown ring. There is usually a brown ring and it turns green in color towards the root of the iris or periphery of the pupillary edge. Now, sectoral heterochromia. Sectoral heterochromia or partial heterochromia. Sectoral or partial heterochromia means what? When one or more portions of the iris has different color from the rest of the iris. Iris means one iris and irises means many irises, two irises. So iris is singular, irises is plural. So sectoral heterochromia or partial heterochromia, when one or more portions of the iris has different colors. When one or more portions of the iris has different color from the rest of the iris, that is sectoral heterochromia or partial heterochromia. Now causes of the heterochromia. Causes of the heterochromia can be congenital or acquired. Now congenital causes are many here. Benign heterochromia, congenital Horner syndrome, characterized by meiosis, that is constriction of the pupil, and hidrosis. And hidrosis means nose wearing. It is characterized by meiosis and hidrosis, partial ptosis, and enophthalmos. We can remember it as a mnemonic MAPE, meiosis and hidrosis, partial ptosis, and enophthalmos. Then Waardenburg syndrome, which is characterized by hearing loss, heterochromia, lateral displacement of the medial canthus, leading to what? Telecanthus. Hypertrichosis of medial eyebrows, hypertrichosis of medial eyebrows, then prominent broad nasal root. And Waardenburg syndrome is because of the neural crest migration defect. Then there is Perry-Romberg syndrome, where there is progressive facial hemiatrophy. It is again a neural crest migration defect, and the melanosomes and melanocytes are derived from the neuroectodermal cells. Neural crest cells are derived from the neuroectodermal cells. So, Perry-Romberg syndrome is because of the neural crest migration defect. Then there is Sturge-Weber syndrome. We know that Sturge-Weber syndrome is characterized by facial port-wine stain, meningeal angiomatosis, unilateral neurological deficit can be present or not, seizures, large facial nerves, ipsilateral eye melanocytosis of the uveal coat or retina, which can be present or not, and it can be associated with glaucoma. Then neurofibromatosis type 1, oculodermal melanocytosis, hematomas congenital melanocytosis, iridocorneal endothelial syndrome ICE, iris ectropion syndrome, and incontinentia pigmenti or pigment. Now, acquired causes are acquired Horner syndrome, siderosis, tumors like intraocular melanoma, nevus, pseudoexfoliation syndrome, pigment dysplasia syndrome, trauma that can be surgical or mechanical, herpes, uveitis, Fuchs, hydrochromic erythrocyclitis, Posner-Schwarzman syndrome, and central uterine venous occlusion, prostaglandin analogs like latanoprost, etc. So these are the acquired and congenital causes of heterochromia, and each one of these I'll be discussing every day along with the anatomy of the iris and rest of the anatomy parts. Like after the anatomy of the iris, I'll be talking about the development of the ciliary body and anatomy of the ciliary body, then anatomy of the sclera and development of the sclera. Then after that, lens. So while covering these chapters related to the anatomy, I'll be covering each day each differential diagnosis or each causes of heterochromia. And heterochromia is a sign, okay? Now I'm going to read one article, okay? That is by Foshin Louis Thomas J. Stockmans on heterochromia, okay? Heterochromia or heterochromia iridium indicates a difference between the color of the two irises. It usually involves the whole iris and can less commonly affect only part of the iris, sectoral heterochromia. It is an often under-recognized sign of both systemic and ocular congenital or acquired diseases. This activity reviews the evaluation and management of patients with heterochromia and highlights the role of interprofessional team in improving care of the patients with this condition. Objectives: review the anatomy and embryology of the human iris with respect to pigmentation and color, summarize the causes and differential diagnosis of heterochromia, outline the important elements in the assessment of patients with heterochromia, explain the treatment of patients with heterochromia. Introduction. Heterochromia or heterochromia iridium indicates a difference between the color of the two irises. It can involve the whole iris or only part of the iris, sectoral heterochromia. It is easier to understand the determinants of iris color with the anatomy of the iris in mind. The iris and ciliary body constitute the anterior uveal coat. The iris is composed of two anatomical layers that both contain pigment. The iris stroma is the anterior layer consisting of loose collagenous connective tissue, the sphincter and dilated pupillary muscles, blood vessels, nerves, melanocytes, and other cells. The posterior layer, the iris pigment epithelium, consists of two layers of cuboidal epithelium. The pigment epithelium layer is derived embryologically from the anterior part of the optical and hence neuroectodermal in origin. The iris stroma is mainly mesenchymal in origin. The melanocytes within the iris stroma and the ciliary body are derived from neural crest cells. Okay. So, iris has got four layers: anterior limiting membrane or anterior border layer, then comes stroma that consists of vessels, nerves, and muscles, sphincter pupillary muscle, Ideally, actually, the third layer is made up of the anterior epithelial and dilated pupillary muscles, but they have divided here as three layers: anterior limiting membrane, then stroma, and then epithelial layers, two layers of the epithelia. The first is anterior limiting membrane, that is made up of the fibroblasts and melanocytes, and then comes the iris stroma, that is made up of the vessels, nerves, ventricupillary muscles, dilated pupillary muscles, mast cells, melanocytes, fibroblasts, clump cells. Then comes anterior pigmented epithelium. Both the layers of the iris are pigmented, okay, but the posterior epithelial layer is more pigmented than the anterior epithelial layer, and the posterior epithelial layer is continuation of the non-pigmented epithelial layer of the iris, and anterior pigmented epithelial layer of the iris is continuation of the pigmented layer of the retina and ciliary body and the iris. So both the layers of the iris, epithelial layers of the iris are pigmented, but the posterior pigmented layer is more pigmented than the anterior epithelial layer, and that's why it is specifically written as posterior pigmented layer, as it is continuation of the non-pigmented layer and it is derived from the optic curve in the layer. So it is initially during the embryonic development, it is not pigmented, but it is pigmented at around 6th week of gestational age. It starts getting pigmented, and normally it loses its pigmentation towards the iris root and it becomes non-pigmented and continues with the non-pigmented epithelial layer of the ciliary body. So it's very important to remember both the layers of the iris epithelial layers are pigmented, but the posterior pigmented epithelial layer is more pigmented than the anterior one. Another important concept is the amount, type and location of the pigment present. A type of cell called a melanocyte produces melanin that is deposited in melanosomes. Variation in the number of melanosomes and the amount of pigment in each melanosome present in the anterior iris stroma determines eye color. The type of pigment affects eye color as well. The main two types of pigment are eumelanin, brown to black pigment, and pheomelanin. The two main types of pigments are eumelanin, brown to black pigment, and pheomelanin, that is red to yellow pigment. Eumelanin is present in the iris pigment epithelium, while both eumelanin and pheomelanin are present in the iris stroma. Lipofuscin, that is yellow in appearance, can accumulate with age and or ocular disease. Eumelanin is present in the iris, brain, and hair and comes in a brown or black form. Pheomelanin is present in the iris, hair, lips, nipples, glans penis, and vagina and comes in a red and yellow form. Pheomelanin. The relative presence of the different types of eumelanin and pheomelanin determines both hair and iris color. Both groups of pigment form from L-tyrosine that is converted to L-dopa-quinone by tyrosinase. Tyrosinase related to protein 1 in turn converts L-dopa-quinone to eumelanin, while the addition of cysteine forms pheomelanin. Biochemistry. Genetics plays an important role in determining the eye color, with up to 150 genes involved and two genes OCA2 OCA2 and HERC2 on chromosome 15 playing a significant role. OCA2 OCA2 produces P protein which promotes melanosome maturation, and HERC2 in turn controls OCA2. The inheritance of iris color is largely determined by two genes as well, EYCL1, ICL1. EYCL1, also called the gray gene, and EYCL3. EYCL3, also called the B2 gene. The grey gene has a green and blue allele, and the B2 gene, BEY2 gene, has a brown and blue allele. The brown allele is dominant over the green allele, and both are dominant over the blue allele. Since many other genes play a role as well, this occasionally creates unexpected iris color. Genes play a role as well. This occasionally creates unexpected iris color. Congenital heterochromia can be inherited, and autosomal dominant inheritance has been reported. In many cases, however, genetic mosaicism can occur when genetic recombination or mutation occurs during mitosis, creating an organism with genetically different cells. In albinism, both the iris stroma and the iris pigment epithelium are affected. Oculocutaneous albinism is inherited in an autosomal recessive manner and caused by mutations in tyrosinase-related protein (TRP), tyrosinase-related protein 1, and OCA2. Ocular albinism is inherited in sex-linked recessive manner. Okay, so oculocutaneous albinism. Oculocutaneous means skin and eye are involved, and they are depigmented, hypopigmented, and it is autosomal recessive. There is autosomal recessive inheritance, and the gene responsible for it is OCA2, tyrosinase related protein 1. And ocular albinism is inherited as a sex-linked recessive manner. Ocular means obviously only eye is involved in albinism, and it is sex-linked recessive inheritance. Eye color changes from lighter tints to darker during the first year of life, with most changes occurring between 3 and 6 months of age. These changes are dependent on adrenergic innervation, Horner syndrome. Lack of adrenergic innervation causes a lighter colored iris that will have a smaller pupil in dark conditions. Other structures within the iris and elsewhere may affect the color of the iris as well. First, iris atrophy from conditions such as pigment dispersal syndrome, as well as iridocorneal endothelium syndrome and iris damage, such as caused by surgery or injury, can cause heterochromia. Second, anisocoria, different pupil size, which can result from ocular trauma, Etis pupil, or Horner syndrome, or an abnormal pupil, such as is the case with iris coloboma, can create the impression of heterochromia. Neoplastic or hematomous structures within the iris, such as iris nemi and leishmanial, can cause heterochromia as well. Finally, asymmetrical corneal changes such as band keratopathy, scalping, and edema can create the impression of heterochromia. Finally, several optical phenomena and light conditions can affect the appearance of the iris. For example, reduced ambient light can cause an amber eye to appear brown. Selective absorption and reflection of other non-pigment molecules such as hemoglobin and collagen describe most of the variations in eye color that are not attributed to pigmentation of the iris. However, relic causing the blue appearance of the sky and tinta scattering as well as diffraction can contribute to eye color as well. Raman scattering and constructive interference responsible for the coloration of bird and butterfly feathers and brightly colored irises of many animals do not play a role in human iris coloration. In addition to the color, human iris tissue may form complex patterns with distinct features. These distinct features can be used for automatic personal identification like fingerprints. Etiology. Most cases of heterochromia are sporadic and isolated benign conditions without any clinical significance. The most important group of conditions with heterochromia are congenital heterochromia, which may be the only presentation of congenital Horner syndrome. There may be associated meiosis, partial ptosis, and facial anhidrosis. Not all these signs need to be present to be diagnosed as congenital Horner syndrome. The iris stromal melanocytes derive from neural crest cells. Stromal melanocytes are derived from neural crest cells. In embryological development, the sympathetic neurons also derive from neural crest cells. Any disruption or sympathetic innervation of the iris melanocytes due to disruption of the postganglionic cervical sympathetic pathways, especially early in life as congenital Horner syndrome, will result in decreased brown melanin color of one iris and heterochromia. Any syndromic illness associated with impaired neural crest cells or tissue development and migration may also cause heterochromia. That is, if there is impaired neural crest cells or impairment in the development of this tissue or migration of the neural crest cell can cause the heterochromia, such as Waardenburg syndrome and Peri-Romberg syndrome. Other congenital diseases include ocular melanosis and neurocutaneous syndrome such as Stolz-Weber syndrome, abnormal hyperpigmented iris. Ocular dermal melanocytosis, nevus of Ota, and neurofibromatosis type 1, that is known as bone buckling Hausen disease, irisomatoma. All these conditions I'm not covering and explaining right now because each condition I'm going to describe in detail along with the standard articles and referring the standard book. I'm going to make video on each of these causes of heterochromia. So rest assured and be patient. I'll be coming back to these conditions and I'll explain them in detail later on, each and every day with one of the differential diagnoses of this heterochromia. Now, congenital causes of heterochromia. Benign heterochromia, congenital Horner syndrome with other presentations of meiosis, partial ptosis, and or impaired facial sweating and hygrosis. Waardenburg syndrome, hearing loss, heterochromia, lateral displacement of the medial canthus, hypertrichosis of medial eyebrows, and prominent broad nasal root. Peri-Romberg syndrome, progressive facial hemiatrophy, Stolz-Weber syndrome, facial port wine stain with meningeal angiomatosis. Patients may present with unilateral neurological deficits, seizures, and a large facial nevus. The ipsilateral eye may have melanocytosis of the uveal coat and retina. Glaucoma is not an uncommon complication. Glaucoma is not an uncommon complication. Neurofibromatosis 1. Leash nodule in the iris associated with other clinical features. Children with neurofibromatosis type 1 may also develop optic nerve pathway glioma, which can be detected by simple ophthalmoscopy showing the absence of ray reflex in one eye. Ocular dermal melanocytosis. Ocular dermal melanocytosis, hamartomas congenital melanocytosis, iridocorneal endothelial syndrome, ICE syndrome, iris ectropium syndrome, and incontinentia or incontinentia pigmentum. Acquired causes of heterochromia, acquired Horner syndrome, other causes of sympathetic heterochromia such as neuroblastoma or paravertebral neurolemoma, ocular trauma, Fuchs heterochromic iridocyclitis, Fuchs heterochromic uveitis, foreign body including use of colored contact lens, iris deposition, siderosis and hemosiderosis, melanocyte infiltration such as diffuse nevus or melanoma, local iris tumors, certain eye drops such as prostaglandin analogs. Epidemiology. Heterochromia is an uncommon sign. There is no widely reported prevalence. Pathophysiology. Human iris color exists in continuum from light blue to dark brown. The most common description uses three shades, including blue, green, hazel, and brown. As discussed above, the most important determining factors for human iris color are the iris stromal texture and stromal melanocytes. The stromal melanocytes are derived from embryological neurocrest cells, which migrate through the ureal tract to the iris during fetal development. Subsequently, the iristoral melanocytes are also under the trophic influence of the post-ganglionic cervical sympathetic pathway. Consequently, any unilateral lesion affecting the cervical sympathetic corner syndrome, either congenital or acquired within the first 2 years of life, will lead to heterochromia. So, any unilateral lesion affecting the cervical sympathetic, for example, seen in Horner syndrome, either congenital or acquired within the first 2 years of life, it leads to heterochromia. That is, first 3 to 6 months of life, the eye is having the lighter color, and almost after that, it acquires its adult color, and the pigmentation, it means it continues to the first 2 years of life till it attains the fully normal color, that is similar to the adult color. Very rarely, long-standing Horner syndrome may also result in heterochromia. Other diseases related to neural crest cell development and migration may cause heterochromia, such as Waardenburg syndrome and Peyronie syndrome. In addition to diseases primarily involving the iris melanocytes, any local eye or iris disease that causes a unilateral change in color, such as trauma with bleeding, melanoma, and other tumors, and fuse heterochromic iridocyclitis. History and physical examination. History: onset acute, subacute versus chronic, important in differentiating local eye disease versus genetic cause. Progressive facial hemiatrophy is typical for Peyronie syndrome. Any local eye symptoms such as pain, redness, and visual disturbances suggest local eye disease. History of trauma, history of use of eye drops such as um, latanoprost, especially used in one eye, causing the discoloration of that eye, and also seen with the other prostaglandin analogs. Family history of neurofibromatosis type 1. Physical examination, most important. Review old photos, especially childhood pictures. Look for the presence of heterochromia in the past and signs of Horner syndrome such as meiosis and partial ptosis. Look for other signs of Horner syndrome, meiosis and ptosis. Look for signs of specific syndromes such as cutaneous neurofibromata, facial hemiatrophy, facial port-wine hearing loss, and broad facial features. Careful examination of the eye is important, especially of the iris. Anterior chamber pupil size is important, and pupillary response is important. Corneal conditions and intraocular pressure measurement. Evaluation: eye examination by an ophthalmologist with a slit lamp examination. Clinical examination, especially to look for other signs of Horner syndrome. Clinicians can use urinary catecholamines (VMA) for excessive sympathetic activities in children to rule out underlying neuroblastoma and other neural crest-derived tumors. CT chest and abdomen to cause CT chest and abdomen to causes of Horner syndrome or possible neuroblastoma or other tumors in children and infants. CT angiogram and CT skull base for hyperplasia of the internal carotid artery as a proof of congenital Horner syndrome or evidence of carotid dissection in chronic acquired Horner syndrome, most of the time with obviously isolated heterochromia and no other abnormal findings on physical exam. The diagnosis will be benign heterochromia. However, no further evaluation plus reassurance is adequate for the management of the patient, treatment or management. Heterochromia is a sign and not by itself a disease. It's a sign and not a disease by itself. It is seen in various diseases as a sign, of which it can serve as a sign. There is no specific treatment of heterochromia by itself. Treatment is directed at the underlying cause, including underlying eye disease, if heterochromia is associated with other signs of Horner syndrome such as meiosis and partial ptosis. The most common cause is congenital Horner syndrome, which does not require any treatment. On the other hand, congenital or early childhood onset Horner syndrome may result from an underlying tumor of the sympathetic chain, especially neuroblastoma, which will need urgent workup, diagnosis, and treatment. Neuroblastoma requires urgent treatment, workup, and diagnosis, while the congenital Horner syndrome it doesn't require any treatment. Heterochromia and long-standing heterochromia caused by an acquired Horner syndrome, especially in adults, signifies a chronic and long-standing illness. The underlying cause is very unlikely to be a malignancy. Differential diagnosis. Heterochromia is a clinical sign. The differential diagnosis will include all the causes listed above. The most important differential diagnosis to consider are benign isolated heterochromia, congenital Horner syndrome with onset before age of 2, acquired long-standing Horner syndrome. Heterochromia is a part of congenital syndrome, local iris and eye diseases including Fuchs, heterochromic iridocyclitis, and melanoma. The prognosis of heterochromia depends on the underlying cause. In infants and children, it is important to rule out underlying neoplasia of the sympathetic chain, especially neuroblastoma, which carries a poor prognosis when diagnosed and treated late. Fuchs heterochromic iridocyclitis may threaten vision due to complications of glaucoma, and iris melanoma may be malignant. The most common cause is benign heterochromia with no clinical significance. The other significant group of causes is congenital Horner syndrome, which usually has a good prognosis. Complications. Heterochromia is a clinical sign and there is no health complication due to this sign per se. Consultation. Ophthalmological consultation is indicated for most causes of local eye diseases causing heterochromia. Oncology consultation is often necessary with suspected underlying neuroblastoma in children, holes, and other issues. It is most important to look old pictures of the patient, especially childhood pictures. The presence of heterochromia since early childhood usually indicates benign heterochromia or congenital Horner syndrome. No further workup is indicated and the patient should be reassured. Enhancing healthcare team outcomes. Heterochromia is a rare yet fascinating sign found in some patients and it may cause unnecessary worries for the patients and families. These patients are usually first seen by their primary care doctors. Interprofessional care and communications between the primary care physician, ophthalmologist, and neurologist will be most effective in determining the cause of patient's heterochromia and appropriate management or reassurance. Making the final common diagnosis of benign heterochromia or congenital Horner syndrome by the healthcare team also helps the patient and family to understand the benign nature of the problem and reassurance about it being a non-inherited problem. Thank you so much.